Hey rad friends, I'm here to discuss a topic of the CTKUB, kidney, ureter, bladder. Normally physicians would order that if they are concerned for kidney stones, and it's normally done non-contrast, although some people say even if they give a contrast study, they can still see the stone. That's if it's big enough, correct? But I'm not a radiologist, I'm just a CT technologist. So KUBs, there's a battle between scanning the patient supine, meaning they're laying on their back facing up on the table, or prone, meaning their belly is on the table and their back is towards the sky, so they're on their belly. So normally, I think, well, it depends on the protocol of the hospital, correct? So follow your protocol, but some people can't lay on their belly, and that's okay. You just, if they cannot, you just note that they're not able to lay prone for the scan and you did your best, because ideally the best scan for a KUB would be a prone study, and that's due to how the bladder sits and where the gravity takes the bladder, whether you're on your back or you're on your belly, and that's to see the junction where the bladder and the ureter meets. That's the ureterovascular junction. So a lot of the times a kidney stone gets lodged in that area of the bladder, where that bladder and ureter meets. So because when a patient lays on their belly, gravity helps the bladder to move forward and away from that junction, and whatever loose, so let's say that this is the belly, this is the bladder, and if your ureter is laying back here, and the loose kidney stones in their bladder ready to be released, there's some stones that will sit back here next to the tubes, and it'll look like it's still lodged in, and it's very painful because it's pretty much clogged and it won't pass through. And sometimes when it's clogged, they have to have like a surgical procedure to get it removed and pushed out or whatnot. But sometimes it's just laying in the bladder, but it looks like it's in the tube, but it's not. So that's why when you actually put the patient on their belly, now the tube's up here, and if the stone actually falls down to the belly because of the gravity, you are confirmed that it's not stuck in the tubes. It's actually in the bladder ready to get passed. So that's the whole reason of scanning the patient prone. And some facilities require it, some don't. Some actually require it, but then some techs don't because of time. It takes longer for patients to lay on their belly. So sometimes they're just like, okay, whatever. But you know better, and you want to get the best scan you can get for a patient. So if they can, and if it's part of your protocol, then try to do so with the patient laying prone. And of course, like I mentioned earlier, if they cannot and they have to lay supine, then they have to lay supine, because that's the best thing you can get, because it's not always in that junction. Sometimes it's still up in the kidneys, and you just need to they need to see where it's at. So that's only if like they kind of know that area. And sometimes when they already know that it's in the pelvis area, they don't even need the kidneys, and you just scan the pelvis because you want to reduce radiation. And let's say that you're scanning for pediatrics. Sometimes with pediatric patients, their bladder, their kidneys and all that stuff, it's very tiny. And sometimes the cuts that comes out, the radiologist will need thinner cuts, because they can miss a stone if it's overlapping and the interpolation, it's not collecting the data and acquiring the images where the stone is. They can miss the stone. So sometimes they want smaller, thinner reconstructions. And if they do, you should already know how to do that. Just go to your raw data and change the slice thickness to maybe like 1, sometimes 2. It's better than 3 and 5s, because you don't want to miss that stone. So 1 would be the best for little pediatric kids. I hope that makes sense. So it's not wrong that you're doing, if you're scanning supine, it's not wrong. You're still going to get it, but it's like more superior. You'll get more data and information and less of a confusion if that stone is actually lodged, because it's a common place to get lodged in that bladder ureter junction. Yeah, lay them flat on their tummy if you can, if you remember. Yeah, because sometimes it's just a non-con belly, but if you read the signs and symptoms, it'll say for kidney stones, and if it's really for kidney stones and that's what you're looking for, then that's what you should do. So yeah. So here is Radiopedia. This is a KUB study. This is what the information I'm getting it from. So this is a supine study, and oops. So if the ureters are back here and the bladder is laying flat on it, and let's say there's a loose stone, it could be sitting in the back of the bladder, and they might think it's part of the junction and it's actually a loose stone. In this case, I don't know. I'm not a radiologist. I'm not here to read. I'm just here to let you know that that's probably why they want it on the belly instead. So here is a patient laying on your belly. You know that they're on their belly because this is the spine. That's the lumbar spine. You can see that there. And so that's towards the top. This is towards the bottom. The belly's coming down. And then now you're going to see the bladder. And now the bladder is towards the belly. It's facing down. You see how the stone is down here? It could be a fibrosis too. That's like, anyway, we're not going to talk about that. But yeah, the ureter can sit here, and now the gravity helps the bladder come down, and it doesn't smash that junction. And then the stone doesn't sit up towards that area. It'll come down, it'll fall down, and then the radiologist doesn't get confused, and it's actually confirmed that it's in the bladder and not in that uretrovesical junction.